Hi, everybody. This is the Rocky Mountain MIRECC Short Takes on Suicide Prevention podcast. I'm Adam Hoffberg, and today we are joined by Drs. Ali Abbas Asghar Ali and Dr. Elizabeth Conti. They're both with the VA Vision 16, which is the South Central MIRECC. They're going to tell us a little bit more about their work, who they are, and what their center's about. Our conversation today will be about collaborative safety planning with older veterans. And welcome, Ali and Elizabeth.
Hello.
Thanks so much for having us.
Great. Well, thanks for being here. Before we get into the topic itself, I do want to learn more about your center, especially because the VA is large and many folks just don't know about how it all fits together. So, Ali, could you go through that a little bit with us?
Thanks again so much for inviting Dr. Conti and me to the podcast. So like you said, we're the South Central MIRECC, and the mission of the South Central MIRECC is to promote equity and engagement, access, and quality of mental health care for veterans facing barriers to care, especially rural veterans. So we do emphasize creating opportunities for rural veterans.
Absolutely. Well, thanks for that introduction. So as I mentioned, today's topic is safety planning. Today we're going to get into a resource that's been developed by Dr. Conti and her team that is a collaborative safety planning approach for working with older veterans. Again, welcome, Elizabeth. Tell us a little bit more about just what is safety planning.
Sure. So safety planning is a brief CBT-inspired technique that's a part of most evidence-based treatment programs in one form or the other, treatments for suicide, that is, dialectical behavior therapy, collaborative and assessment, management of suicidality. These all include some form of a safety plan. So it's been around for a long time. And in the VA, safety plans are actually required for veterans who are high risk, veterans who come into the ER with psychiatric emergencies, and at least at our hospital, veterans who are discharged from inpatient psychiatric stays. So a lot of people are using safety plans, and really what it is just a guide for what the patient is going to do the next time they're in crisis. So it's a list of warning signs, coping strategies, people they can call for help, and plans for reducing access to lethal means. So in a nutshell, that's what it is. And like I said, it's really based on strategies that have been used for a long time. I think what's unique about what the VA does is using it as a standalone intervention, and we really want that intervention to be as robust as possible, which is why I created this tool.
Excellent. And I understand that the word collaborative is explicitly and implicitly implied with safety planning. Could you tell us, what does it mean for something to be collaboratively developed?
I think one of the misconceptions about safety planning is that it's very simple, because safety plans are often written on what looks like a worksheet. So one page that just has different blanks that you fill out for the different sections. And it's really a lot more than that. Ideally, it comes out of a therapeutic conversation that a provider is having with a veteran about what it really looks like when they're in crisis and what very particular personalized things that they're willing to do. So I think the collaborative piece, what I was seeing clinically is sometimes that was missing. So sometimes a person would be asked to fill out the safety planning worksheet, and then that information would be entered into their chart. And it was really a missed opportunity, I thought, for this potentially therapeutic conversation between the provider and the veteran. So that's what I mean by collaborative, is troubleshooting, talking through pros and cons, making sure the veteran understands how, when, and why to use the safety plan, and not just that it exists.
Great. That's really helpful. Specifically for this resource, we're thinking about older veterans. Can you tell us a little bit about what do we mean by an older veteran and why focus or target a resource specifically for this population?
I've been interested in suicide prevention in older people throughout my graduate training. So for me, that was a natural area of where I would focus. Middle-aged and older men are at really high risk of suicide compared to other groups. And then when we move into the veteran population, those are a lot of the people that we treat. So I think it's a natural thing to focus on older adult suicide prevention, especially among men, especially among veterans, because they tend to be higher risk. And then I think there's things on the safety plan that can be tailored for older adults. For one thing, older adults might have changes in their medical conditions or their physical abilities. They might not be able to do the same things that they used to be able to do. And so explicitly considering that when you're making the safety plan can be helpful. I also saw that although there are existing safety planning resources out there, and they were extremely useful to me when I was developing this, but I didn't see anything related to dementia and safety planning. Where I worked clinically, we saw a lot of folks who came in crises related to dementia, actually, and they were having to do a safety plan before they were discharged from inpatient. And there was a lot of confusion about whether that was appropriate, whether a safety plan could be conducted or might be helpful. So I wanted to do an exploration of that, ask the experts, and then put together a set of recommendations for people with dementia. There's a couple other factors I'm sure we can get into it about other things that we would recommend for older veterans.
I think that's extremely well said in terms of thinking about this resource as targeted to a group that may be at higher risk than other populations. And so having a resource that's really tailored towards specific needs like dementia or other cognitive difficulties, it really makes sense that you went ahead and produced this resource for this population.
Yeah. Another thing that seems really common in older veterans is a lack of social support or family support, and also a reluctance to seek help. Of course, we see that with a lot of different populations, but throughout this guide, I really wanted to emphasize increasing social support and reaching out for help as potentially a first option instead of an option of last resort. So that was another thing that when I asked the experts, especially Dr. Kim Van Orden, who works at the University of Rochester, she studies older adults and suicide, and that was actually a suggestion that she made, that we really emphasize help seeking, even though that comes later on the safety plan.
Okay, well, I think that's a nice segue to talk a little bit more in detail about what makes up the safety plan. You went over that generally, but one of the things that caught my eye in the description was this idea of the safety plan as a menu of options and not just a pick one type of solution or plan, crisis response plan. Can you go over a little bit more about how you see it as a menu of options and what those options might include?
We never want to discourage someone from seeking help. So traditionally on the safety plan, we ask that the person basically try to solve the crisis themselves first. So they use internal coping strategies. Those could be things like deep breathing or using other kinds of distraction. And when we think about people for whom DBT is focused, for example, these might be people who have a lot of emotion dysregulation, who really need a lot of coaching at coping with their own problems. A lot of older adult people who are at risk for suicide don't really fit that profile. And in fact, they might be more on the profile of just being really lonely, isolated, depressed, having medical problems, and those kinds of things are more prevalent. On the safety plan, it looks like the first thing we ask them to do is to try to cope themselves, internal coping strategies without contacting someone else. For older adults, I would make the tweak that this is a menu of options, that if they want to start with reaching out for help, that we fully support that. There's no sort of asking or requiring that they try to use internal coping strategies before they reach out for help.
Okay, so that's helpful in the sense that it's not like you try the first step. If that fails, go on to step 2. If that fails, go on to step 3. It's more, here's a few different options. If reaching out for help is a good step for you, then take this step. If you want to try something internally, deep breathing exercises first. And if that's what you think is good for your plan, you go that route. Is that kind of what you're getting at?
Exactly. So I think some providers with some patients would use the safety plan like you really should try to use your coping strategies before you reach out for help. And for some patients, that's totally appropriate. But that's not what we would recommend in general for older folks, just because we really want to encourage them to seek help.
Okay, and so we've talked about internal coping strategies. We've talked about reaching out for help. What are some of the other options on the menu for safety planning?
There's actually 3 different sections on the safety plan that involve reaching out for help. So I'll kind of break those down a little bit more. So the first one is reaching out to people and places for distraction. So this would be calling up your friend or your cousin who always has something going on, and you know you can always talk to them, and they're going to make you feel a little bit better just because they'll distract you. And you don't have to tell them about the crisis. So in that step, we're not expecting veterans to reveal that they're having suicidal thoughts. So that's one part of the safety plan. So in the next section are people who they can actually reach out to for help, people who they feel comfortable admitting that they're in crisis, or that they're having suicidal thoughts or whatever's going on, people who they trust, a close family member, a spouse, a close friend, maybe even a pastor or something like that. So that's its own step. And then step 5 on the safety plan is reaching out to professionals. So that would be their therapist, their psychiatrist, and then emergency numbers. That's why actually 3 steps out of 6 on the safety plan are about reaching out to other people, but in slightly different ways and to slightly different people.
Yeah, that's, again, very helpful in terms of realizing that that's such a big part of safety planning is this reaching out for help and making sure that that's spelled out very explicitly with all these different categories of people that you could reach out to, whether it's a clinician, whether it's a family member, whether it's friends. So it sounds like the safety planning is really meant to be like a one-stop shop for people that you would call to turn to for help.
Yeah, it should be a comprehensive place for them to go. You really want to have as many people as possible listed on the plan because, of course, someone might not pick up the phone, or for whatever reason, the veteran might not want to call that particular person on that day. There's also, I think it's really worth talking through with the veteran what professionals and what emergency lines they would actually use, because they may know that their doctor never picks up their phone, or they may know that they never want to call the crisis line because they have some sort of conception of what will happen if they do. Even talking through those options, I find to be really valuable.
Yeah, that's a really important point because obviously if we have these numbers on there, we don't want to just be going through the motions. We want to make sure these are numbers the veteran will actually call. Thinking about that and going back to this collaborative idea that we're not just putting numbers on there, they're really informing this process.
Exactly.
Okay, so let's talk a little bit about some of the other steps that don't involve contacting other people.
So the important step that we haven't talked about yet is the last step, step 6, which is euphemistically called making the environment safe. I think it's a little bit of an unfortunate labeling. There's different versions of safety plans, but the ones that I've seen most often in the VA use this term, making the environment safe. And it's a little bit of a misnomer. I think sometimes providers and veterans aren't totally sure what that means. And what that really refers to is means safety, otherwise known as means restriction or reducing access to lethal means. The one we want to be most serious and careful about is firearms, asking if there's firearms in the home and making a plan for what to do if there is a firearm in the home of someone who is suicidal. Other means could include, of course, things like razor blades or ropes, stockpiles of pills. So that's the time to talk with the veteran about what they've thought about doing as far as ending their life and how they might reduce their access, because we know that reducing access to lethal means is an effective way to prevent suicide.
Right, and we can't emphasize that point enough. I know that's one of our big talking points as far as suicide prevention and reducing easy access to lethal means. And, it is nice or reassuring to see that is built into the safety plan. And thinking about older veterans as our population, why might this step be particularly relevant?
Well, older veterans are older people in general, older Americans, are more likely to die by suicide using guns than younger people. Really, the need to have a conversation about firearms can't be overstated for this population. I understand this is a very difficult conversation often for providers and for veterans. So I pulled some resources from Craig Bryan and other people to create a menu of options for means restriction. So things like using a gun lock and giving the key to a spouse, so the veteran doesn't lose possession of the firearm, but the firearm is less deadly. And again, it really goes back to that collaborative approach. Whatever the veteran is willing to do to make themselves more safe, whatever they're willing to agree to, and as a provider being really sensitive, people often don't like being questioned about their guns. And I think that's a challenge that providers who talk to their patients about suicide run into. So we want to give, again, a menu of options of things that will reduce access to lethal means. And really, it takes time. That's not something that can happen just by the veteran filling out a piece of paper. That it really needs to be a conversation. And to save some time for that conversation is really important when doing the safety planning process.
So how long do you think, and obviously it's going to differ, but how long should a provider set aside or plan for having a collaborative discussion about the safety plan?
It varies a ton. I find that it varies a lot based on what's going on with the veteran, how much experience they have with talking about coping strategies. If they've done safety plans in the past, that makes a huge difference. So I would say probably approximately 20 to 30 minutes to really do this well and to do this collaboratively. But if the person already has a safety plan in their chart, what I would recommend is printing that out and then just going over it collaboratively, making sure that every step is still relevant. You can ask them, well, did you do this last time you were in crisis? Did it work? Do you want to change it? So that's probably a quicker version. The longer version often happens when people are still kind of actively in crisis. Like I see people a lot in inpatient who just sometimes aren't quite ready for this conversation. It's hard to focus on something as concrete as a safety plan. So that's more challenging, but I just try to gently but firmly keep people on task. I tell them this is something they're going to have to do anyway before they leave the hospital, and that I'd really like to do it with them in the time that we have. I would estimate 20 to 30 minutes. So that's half of a regular therapy session. That's a long psychiatry visit, but you can also break it up between sessions, check in on people when they come back. It's not something that should take 20 or 30 minutes every time you discuss it with a veteran.
Right, and I'm glad you alluded to the idea that this is not a one-time process either. It sounds like this is being revisited, revised, updated as things play out, and new resources, new people to call, other people that you don't think are good fits. So it sounds like this is a document that's always in progress.
Absolutely. And I think about it a little bit as like a tiny mini DBT session, because in DBT, a lot of what you're doing is figuring out what coping strategies to use in whatever, life situations come up throughout the week. And then people who are in DBT therapy, they'll check in every week. How did that go? How did that go? What did you use? Why didn't you use it? And so if you think about safety planning in the same way, that we're trying to give them a little bit of that type of intervention. And so checking in on it regularly is a really excellent way to increase their safety.
Mm-hmm. Just expanding on this collaborative process, because as you mentioned, it sounds like such an important piece of making an effective safety plan. And you touch on the idea of motivational interviewing techniques, and that's a term that most people may be aware of, but maybe some not. Could you tell us about what is motivational interviewing and sort of how it's used when safety planning?
Well, I recommend everyone reference the book, the Miller and Rolnick book on motivational interviewing. I just think it's really inspirational as a therapist, and they have a lot of great points about talking to people about change. But the basics that I included in my manual, things like reflective listening, using open-ended questions, using summary statements, and just a real general sense of partnership and coming alongside the person. So this is not entirely consistent with a motivational interviewing stance, but we have an outcome that we're interested in, and that outcome is getting them to use the safety plan. And so by taking a more motivational interviewing stance, we can really be open to their concerns about what might happen if they use the safety plan, or any ambivalence they have about using it, reflect that, ask questions to learn more about their ambivalence, and then hopefully get to a point where they can come up with their own solutions for how it's going to work with them in their life.
And you mentioned this idea of like an open stance or coming beside them. Do you literally mean like sit next to them, or can you describe how this might look in the actual office? Sure.
That's one thing that I include in my manual that I like when David Jobs talks about that in CAMS, of actually sitting next to the veteran and writing on the form together. I think that's a great idea. A lot of older people don't love to write. I think definitely sitting down with them, what I've learned for nurses and psychiatrists is often a real luxury, to be an inpatient and to actually sit down with the patient. That sometimes doesn't happen. And so I think what it communicates to the patient is that this is going to be a longer conversation, and that by sitting next to them instead of across from them over a desk, that it's more of a collaborative stance and a collaborative process.
Excellent. Any other practical in the office strategies for completing a safety plan and just considerations for working with older veterans that you'd like to share?
There's a lot of different ways that the veteran can take the safety plan with them. So once you create it, it's sort of not enough to just have it created or have it in the chart. Then you kind of have to decide how the veteran is going to have it with them at all times because they don't know when they might need it. So I also created a card that goes along with my manual that is just like a little wallet card where you can write the safety plan. So that's a super practical aspect of actually making it useful, is getting it in a form that they can carry around. There are also really great iPhone apps. I'm sure they're for Android too. So there's apps that you can enter the information, and then as long as they have their cell phone, then they would have the safety plan with them. That's pretty critical, that they have the actual phone numbers on the plan. Things can happen. Maybe they don't have their phone with them, or they need to use a different phone. So we encourage people to actually have the phone numbers written on the plan.
Yeah, that makes a lot of sense, and especially if we're thinking about older veterans, just may not be as tapped into the mobile apps, and having this physical hard copy may be a better fit. I was just going to say that we'll definitely post a link to the wallet card addendum to the manual as well, so that folks can have not only the manual to coach you through the process, but have the wallet card that can be printed out to be used so that the veteran has it on them at all times.
Yeah, and then just following up on some of the changes for older adults, another practical consideration is how to involve family members or even staff from the place where the older person is living. And that can be quite challenging depending on what exactly is going on, if they're in inpatient. But if you have someone who has mild to moderate dementia, it's appropriate to involve a family member in the creation of the plan, but also the execution of the safety plan. So let them know what the plan is for means restriction, let them know what some of the coping strategies are that the veteran is comfortable with using, et cetera. And then I think if the person is in a nursing home or some other type of residential setting like that, it's probably good to communicate with the staff about their suicide risk, but also to ensure that they don't have any access to lethal means. It's probably the most important.
Very good. Thank you so much for breaking this down and really talking to us about safety planning and for developing this resource, because it does sound like it's so useful. We're happy to help promote it. Any other final thoughts, closing remarks to providers, or perhaps an older veteran listening in on the podcast? Any takeaway messages for them as well?
Sure. I mean, I just want to thank all of the different types of providers who do safety plans. I was really blown away by how many different types of providers, nurses, trainees, social workers, psychologists. I mean, there are a lot of different people who are using this intervention, which I think makes it pretty exciting. So I want to thank everyone who works with suicidal veterans, because I know it's definitely not easy. I would say that we have strategies that work, and we want to promote them as much as possible. I'm very excited about safety planning and other interventions like that. So I'm just so glad to be able to talk about it more and to have had the opportunity to speak to a lot of different audiences now about this project.
Great. Well, thanks again, and we are happy to help promote this product. Ali, do you have any closing remarks for today?
No, I just wanted to once again thank you all and thank Dr. Conti. I think she did an excellent job of explaining not only the rationale, but the ways in which people could use this and also improve their overall ability to work with people with suicidal ideation and attempts.
Yeah, I second that. I mean, it's important that, we have these tools out there. We know suicide is preventable, and now part of our educational mission is to make sure that these tools get in the hands of folks who put them to good use. Again, thank you for sharing this information with us today, and hopefully folks can begin to use this manual and give us feedback, and maybe there'll be a version 2 down the road with their feedback.
Sounds good.
Yeah, that'd be really great. And I also wanted to thank my collaborators and my co-authors here at the Houston Michael E. DeBakey VA Medical Center, because it wouldn't have been possible without them.
Great. Well, everybody, again, thanks for listening today. You can learn more about the work at the Vision 16 MIRECC and, of course, also download this manual to coach you through collaborative safety planning with older veterans. Again, feel free to reach out to us with comments, questions about the manual, or feedback, good and bad. Things to improve are always helpful. And give us a review, share with your colleagues. Until next time, this has been the Short Takes Podcast.